There are about 20 more events happening. If you don't know about this, if you go to 10 events, you have a chance to win a $500 tuition waiver. A chance, doesn't mean you will win, but it's still a good chance, either in the spring or summer that you can look for. So just the 10th event that you go to, just give it to us. Make sure your name is in it, and you might win. I'll let you know. So at the end of this event, I'll be at the corner, and I'll stamp your passport if you have one. If you do not have one, I'll give you one. Okay? So there's also going to be October 18th and 19th, a Japanese festival, 2 days, all day. A lot of things are happening. Some ninjutsu practitioners, real ninja, are coming, and some dancers. Traditional Japanese dancers. Ah, that's much better. So if you didn't hear me, I'll be up there at the very end to give you stamps. Thank you very much.
All right, well, good evening. My name is Dr. Matthew Moore, and I'm the Director of Debate here at UCO. We've been asked to have members of the debate team come up here and have a debate that kind of ties in with the topics of the class and the topics of the passport to Japan. In tonight's debate, we are going to debate the issue of healthcare reform in America, which is something that's dominated the political agenda for the past few years. What we are going to discuss are the implications for whether or not the United States should adopt a Japanese style of healthcare based off of their insurance program. Now, there's a lot of differences and a lot of similarities between healthcare in the United States and Japan, but we chose this as one of the glaring differences. In Japan, their national health insurance program currently runs on what is known as a multi-payer national health insurance system. Insurance premiums are compulsory, which means as a mandatory part of your paycheck. They are salary-based, and they're split between both the employee and the employer for most of the country. The average contribution for an employee in Japan is about 4% of their salary goes towards payments into the health insurance system. This system includes more than 4,000 public and private payers, and there's no discrimination based off of prior health status or pre-existing conditions. Also, a key difference though is the insurance companies do not earn any profit off of the system. Insurance is available either through the national health insurance or the employer health insurance programs, depending on where you work. The United States has a radically different program. Insurance is available through employers, private companies, or for those who qualify, government programs such as Medicare. The vast majority of American insurance is provided by employers, such as government institutions, businesses. And if you have a job, part of your benefits package is usually access to employer insurance. Under the Patient Protection and Affordable Care Act of 2010, individuals in the United States are now required to have some level of health insurance. And tonight, we are going to discuss the hypothetical if we were to replace that with a mandatory system that is based solely off of government providing this common pool as opposed to a multi-tiered system such as the United States. Representing the affirmative is Greg Monday. Greg is a junior from Bartlesville, Oklahoma, and he will be arguing that the United States should adopt the Japanese-style system. Representing the negative is Michael Yost. Michael is a senior from Tulsa, Oklahoma, and he's going to defend the current U.S. healthcare system as it is. Each side is going to give 2 speeches, and afterwards we'll have a brief question and answer period. So please save all your questions for the end, and we'll have plenty of time to do that. So without further ado, I present to you Greg Monday.
These chairs are very, very loud. Just informing you all. Okay.
In the United States, there are currently 48 million uninsured people. Of these 48 million, they are all part of the 84 million that report being uninsured or underinsured in the last year. That is nearly a third of the population of the United States. With a nation with the largest economy in the world, there is little reason for us to be behind many of our international peers when it comes to healthcare coverage. Even with increased coverage under the Affordable Care Act, the United States will still be lagging behind many of other countries. The best example of what we should be wanting out of this country is actually Japan. The Japanese healthcare system has led to a population with the highest life expectancy of anyone in the world and an infant mortality rate of nearly half that of the United States. The problems in the United States are both easily observable and incredibly dangerous. The lack of healthcare insurance access is prevalent in the United States right now. The Census Bureau in 2012 stated that 15.4% of people were uninsured, down from 15.7% in 2011. But the number of uninsured people, 48 million, was not statistically different from an estimate of 48.6 million people in 2011. This lack of healthcare insurance undermines the healthcare system as a whole, and really, access should be the basis of all healthcare systems. People should be able to go to the doctor when they need to instead of having to wait for hours waiting to be seen. Christopher Wamjek, the author of Bad Medicine and Food at Work, wrote in 2009 that convenient access to healthcare with its inherent emphasis on preventative medicine should be the hallmark of any system. The United States lags far behind. The well-publicized issues of millions uninsured or underinsured is only part of the story. Many more with health insurance avoid doctors, disgusted by the time it takes, an often useless process involved in going to the doctor. It is even more problematic when you consider that different states and different levels of wealth vastly change an individual's options. Healthcare access is spotty in the United States. It varies state to state, varies by health. Even after the ACA, millions will be undercovered, increasing the likelihood of bankruptcy or avoiding care. The reason it is so harmful is that private insurers control the costs. This allows for insurance costs to be prohibitive for plans that provide worthwhile insurance, making it less likely to change. The multi-tiered coverage system is harmful for those with the bottom tier of coverage. And affordable plans under the ACA will have high deductibles and little provider choice. A report done by the United Health Center for Health and Reform Modernization found that rural Americans have less access to health insurance and also have worse access to good healthcare providers. Also stated that these problems aren't going to be solved with the passage of the ACA. Also, the Affordable Care Act's Bronze Plan has a maximum deductible of $6,350 for an individual or $12,700 for a family plan. And plans have to cover 60% of the cost post-deductible, or in the case that it's pre-deductible, 60% of the cost on all insurance. This means that if you have a major expenditure that you are capable of spending over $6,000 out of pocket if you are single before you get that 60% coverage, meaning you would still have to pay nearly half of the bill. This means that the average hip replacement surgery, a $25,000 procedure, would cost a patient around $14,000, or about the average cost of a year of college. Even without including our national average of $1,000 for an ambulance ride, the cost of a 3-day stay at a hospital after a severe accident is about $7,400, costing you about $3,000 after insurance. Secondly, the lack of insurance or being underinsured is leading to rising medical costs and health issues. The Commonwealth Fund of 2008 found that declining insurance coverage and rising healthcare costs are likely contributing to skimping on needed care. The share of U.S. adults reporting that the cost of healthcare prevented them from getting needed care increased from 29% in 2001 to 45% in 2007. Reports of cost-related access problems rose across all income groups and among both insured and uninsured adults. And this makes a continual spiral out of the healthcare system. Individuals don't have money to pay for a doctor's visit, so they avoid it, meaning their issues get worse, leading to a more severe treatment when they finally have no other option but to go to the hospital, which will cost them more money, leaving them in debt or filing for bankruptcy, ultimately leading to a pattern of illness and death. Third, rising costs are increasing the previous problems as well as other problems. The Kaiser Family Foundation in 2013 wrote that the rising cost of healthcare is making it prohibitive for those without wealth to attain medical services, meaning they can't go to work when they get sick, pulling the overall economy down. This negative feedback into the system will make it even harder for the United States to get out of its current economic woes, and will increase the cost of the healthcare providers due to not getting paid for their services. And the Affordable Care Act will not be able to solve all of these problems. Economist Timothy Taylor wrote that since well before the passage of the Act, it has been clear that it would not provide universal health insurance coverage. For example, there's a White House announcement in September 2010 predicting that the Act would reduce the number of Americans without health insurance from 50 million to about 18 million. The Congressional Budget Office estimated last spring that the implementation of the Affordable Care Act would reduce the number of Americans without health insurance from 55 million in 2013 to 31 million in 2016, with almost all of that drop coming from people starting for the new insurance exchanges, and some coming from expansion of Medicaid. By 2023, there would still be 31 million uninsured. So after all the tumult and the shouting over the Affordable Care Act, both during and after its passage, its supporters optimistically expected to solve about 60% of the problems of Americans lacking health insurance. And in fact, it now seems more likely to only solve for 40% of the problem. This lack of affordability leads to thousands of unnecessary deaths per year. As the study from the Commonwealth in 2013 found, if healthcare access and care experiences among vulnerable populations in all states were to attain benchmarks for higher income or otherwise more advantaged populations, we might see the following gains. Over 30 million more low-income adults and children would have health insurance, reducing the number of uninsured by more than half. About 34 million fewer low-income individuals would face high out-of-pocket medical costs relative to their annual income, and about 21 million fewer low-income adults would go without needed care because of cost. About 11 million additional low-income adults over age 50 would receive timely preventative care, including cancer screenings and immunizations. 750,000 fewer low-income Medicare beneficiaries would receive an unsafe prescription drug. There would be over 300,000 fewer readmissions within 30 days of hospital discharges among low-income Medicare beneficiaries. Fewer people would die prematurely, resulting in about 6.8 million potential years of life to work and participate in communities, or 86,000 fewer deaths each year, assuming average life expectancy. 33,000 more infants born to mothers with a high school diploma or less would survive to see their first birthday. All of this can be solved through a simple plan. We should establish a multi-payer universal health insurance fund similar to that seen in Japan and modeled after it. First, the Japanese multi-payer universal health insurance fund is able to fix the problems present in the American system and likely to be present even after the Affordable Care Act. The American Bar Association in 2013 stated that in a multi-party system, there are often different types of cost containment, which may be offered by different health insurers, such as various sizes of deductibles or co-payments which would affect quantity of service delivered. Over time, there have been innovations in cost containment among health insurers in a multi-party system. Outpatient surgery, which is less expensive than inpatient surgery, is now common. Pre-certification has reduced hospital admissions, and concurrent reviews have reduced the length of stay in hospitals. There are a large number of health maintenance organizations, HMOs, and preferred provider organizations, or PPOs, which also attempt to contain costs in addition to traditional fee-for-service plans in the health insurance industry. Secondly, the multi-payer system provides better quality of care. From the same study from the American Bar Association, it states that under a single-payer system, there is no market incentive to provide information on the quality of care of individual hospital or physician providers, or to only contract with physicians or hospitals which have best practices. Each provider automatically is a fully participating physician or hospital in a single-payer system. With a multi-payer system, one would expect some payers to contract with the purportedly better quality hospitals, such as the Cleveland Clinic or the Mayo Clinic, and superior physicians so that they may emphasize that they have a health plan which contracts only with the best providers of health care. This allows for companies to compete based on hospitals and other questions of quality rather than on questions of cost. Third, the Japanese healthcare system leads to a healthier society overall. In an article from the Journal of Medicine, they stated that Japan's healthcare system is designed to make medical services available to all citizens via employer-purchased insurance and to control healthcare expenditures. This has resulted in one of the healthiest nations in the world at one of the lowest costs. Fourth, Japan has the highest average lifespan of any country. The Japanese health ministry showed data that presented girls born in Japan in 2012 with a life expectancy on average of 86.41 years, up from 85.9 years in 2011. Japan also has the lowest infant mortality rate of any OECD country and is second in the world, only to Monaco. Japan is number 2 in the world at 2.17 infant deaths per 1,000. Number 1 is Monaco at 1.81,000. Japan's system is nearly half the cost of the United States system on top of all of its major benefits. In a World Bank report, they found that Japan has 9.3% of their total GDP in health spending. The US, on the other hand, has 17.9% of their total GDP in health spending. Lastly, the multi-payer system presents the best of single-payer and private market-based insurance into a single method. The United States Bar Association once again states when government interventions are introduced, it appears that in addition to cost containment, potential improvements in paying for quality of care and reductions in cream skimming can be accomplished in a multi-payer system. In contrast, inefficiencies are still inherent in a single-payer system. If governmental reforms in the multi-payer system can be successfully accomplished, as they happen in Israel and the Netherlands, the direction for the United States health system may be somewhat clearer. With even a small amount of government intervention, a multi-payer system can effectively nullify the problems inherent to both of the major alternatives, while preventing insurers from providing minimal benefits in an attempt to curb costs. So, to conclude, following the Japanese model will allow for a more effective healthcare system that is better capable of dealing with a large base of people like the United States and is necessary for the continued health of the United States citizens. Thank you.
The problems with the United States' healthcare system are well documented. Certainly, the U.S. spends much more on healthcare than many other nations, provides coverage to fewer individuals while experiencing mixed outcomes in measures like life expectancy and infant mortality. But we shouldn't let the system's failures obscure the very many positive aspects of American healthcare. Indeed, many of the measures of quality of care highlighted by my opponent are flawed metrics to evaluate the quality of our healthcare. In terms of the effectiveness and innovation of the American healthcare system, our system ranks among the very best. Finally, the Affordable Care Act has addressed and will address many of the system's failings, particularly in terms of the coverage of the uninsured and the rising cost of healthcare. The most important question for evaluating the quality of a healthcare system is determining which measures to use to make that evaluation. My opponent points out two measures: overall life expectancy and infant mortality rate. These sound persuasive, but they're deeply flawed measures, simply because there are so many other factors that go into play in determining these two outcomes. We can all agree that the Japanese tend to live longer and experience fewer life-complicating procedures during birth. However, these are not the result of their healthcare system themselves. There's many other things, like lifestyle choices, that determine the outcomes of these two metrics. In particular, Japan's people consume a much more healthy diet than Americans do and have a much more healthy lifestyle. Both are key contributors to a long lifespan. According to the OECD, only 4% of Japanese have a body mass index over 30, which is defined as overweight, compared to over 30% of Americans. Additionally, the U.S. has 10 times as many homicides and nearly twice as many accidental deaths from things like transportation, things like car crashes. These things have nothing to do with the quality of our healthcare, but they are important for determining life expectancy and infant mortality. Two professors, Robert Oatsfeld and John Schneider, conducted a study in 2006 which compared life expectancy among various countries controlling for factors like homicides and transport deaths, and found that once these factors were removed, the U.S. actually has a higher life expectancy than Japan, suggesting that our healthcare system is much better than given credit for. As for infant mortality, that particular measure is problematic because of the inconsistency of measurement across countries. There's simply no universally accepted way of defining infant mortality. For example, Japan counts all stillborn infants as pre-birth deaths, excluding them from their infant mortality rate, whereas the United States includes them in their infant mortality rate. One study by Dr. Eric Gibson found that this inclusion can overstate the infant mortality rate by as much as 40%. All of these facts should drive home the point that looking at population-wide measures affected by other things than healthcare is not the best way to evaluate the quality of our system. Instead, a better way of evaluating our healthcare system is to look at mortality rates for people who have already been diagnosed with the disease, for example, heart disease or cancer. This will control for extraneous factors like lifestyle choices. When we look at these measures, the U.S. healthcare system looks very good. Take heart attacks, for example. Heart disease is the #1 killer of Americans, and one of the primary causes of death in Japan. In this comparison, the U.S. fares very well. Around 10% of heart attack victims die in Japan, compared to just 4% in this country, according to a study by the Commonwealth Fund. The U.S. also does a much better job of ensuring that cancer victims stay alive. A study by the British medical journal The Lancet found that the 5-year survival rate for people diagnosed with various kinds of cancer was 74% for the U.S. compared to just a 63% survival rate in Japan. What we should learn from these kinds of statistics is that while Americans are much more likely to be unhealthy in the first place, our healthcare system does a much better job of responding to those unhealthy lifestyle choices which are inherent in American culture. As a result, we should be extremely cautious of moves to give the government a greater say over healthcare delivery. The first reason why can be seen when we compare various healthcare programs in the United States. The U.S. has not one, but 3 different healthcare systems, and soon to be 4 with the Affordable Care Act. First, there are people with private sector insurance, for example, provided by their employer or that they purchase, for example, in a university setting. There are those who receive Medicare benefits, which are people 65 and older. And then there are people who receive Medicaid benefits, who are people who who have low incomes and do not qualify for other programs. Several studies all note that those who are on private insurance plans have by far the best health outcomes. We shouldn't be surprised by this. Private competition allows people to have more say over the terms under which they receive health care, who their doctors are, what treatments they receive, and so on. All of this choice translates into better health outcomes. It also translates into a more innovative, technologically advanced healthcare system, since patients get more of a say over getting new and experimental treatments, which might not otherwise be available in a system like Japan's, where the government gets to choose which treatments are reimbursed by government funds and which benefits health insurance provides. Innovation happens when companies are rewarded for investing in innovation, and that happens best under a private system. Price controls managed by a government entity instead hamper innovation by restricting returns on investment. The evidence on this is overwhelming. In terms of innovation, no other country's healthcare system comes even close to the United States. According to Michael Tanner, a healthcare expert with the Cato Institute, 18 of the last 25 Nobel Prizes for medicine were awarded to either Americans or people working in the United States. Moreover, American pharmaceutical companies are responsible for over half of the new medicines introduced in the past 20 years. Finally, Americans are responsible for some 80% of all non-pharmaceutical medical advances, for example, in medical technologies in the last 40 years. If we want new treatments that give patients a better shot of fighting all the medical conditions that threaten all of us, then we should be skeptical of moves that seek to overhaul the American healthcare system. I will acknowledge that the American healthcare system is not without its issues. Tens of millions of people remain without health insurance, and costs are indeed very high. These are not small problems, and it's right that we should want to address them. But what is needed is pragmatic reform, not radical overhaul. And the Affordable Care Act passed in 2010 will do much to resolve these problems while leaving the basic structure of the American healthcare system intact. In terms of the uninsured, there have been historically 2 major barriers to providing health insurance to everyone. First, you have people who are already sick and therefore can't afford coverage of health insurance because of pre-existing conditions. The second group are healthy, young people who simply don't want to buy health insurance because they don't see a benefit to it. The Affordable Care Act fixes both of these problems. First, it requires insurance companies to accept all applicants, regardless of pre-existing conditions. And second, those with pre-existing conditions are to be offered the same rates as everyone else under a policy called community rating. These 2 requirements will go a long way in making health insurance affordable for people who cannot afford it now. The second group of people, those healthy and young people who voluntarily opt out of health insurance, are those targeted by the Affordable Care Act's individual mandate. The Affordable Care Act requires those people to buy health insurance or otherwise pay a tax which helps fund health coverage for other people. By opting out of buying health insurance, this group drives up insurance premiums for everyone else. by reducing the risk premium available to insurers. A larger group of people buying insurance in turn drives down costs for everyone else. Independent estimates by the Robert Wood Johnson Foundation estimates that the Affordable Care Act will reduce the number of uninsured by some 30 million people, with most of the remainder undocumented immigrants who wouldn't be eligible for government benefits regardless of which system we choose, the American or the Japanese system. The second problem with the American healthcare system is the large costs and high levels of medical spending. To this end, the Affordable Care Act contains a number of provisions that will help address this problem. First, it taxes so-called high-end Cadillac health plans, which account for a large portion of medical spending, incentivizing more modest insurance plans, which cost a lot less. The second major way that the Affordable Care Act addresses healthcare costs is by encouraging value-based insurance payments instead of a fee-for-service payment. One of the big problems with both the Japanese and American healthcare programs is that they're driven by this fee-for-service model, where healthcare providers are reimbursed by insurance companies based upon the amount that they spend on a service. So this has some deleterious effects. If two equally effective treatments for disease exist, but one costs $10 and the other costs $1,000, the hospital will tend to choose the one that costs $1,000 because it allows them a greater profit on a more expensive treatment, while consumers are shielded from the cost of that decision because insurance will cover the cost. The Affordable Care Act resolves this by shifting the cost of more expensive treatments onto hospitals or consumers rather than insurance companies, which will provide better incentives to make sure people choose low-cost options as opposed to high-cost options. Economists are virtually unanimous in their support for these measures. According to Professors David Cutler and Nikhil Sawhney, healthcare cost increases in the U.S. are at their lowest levels in half a century, and the Affordable Care Act is a big reason why. In summation, the American healthcare system gets short shrift in popular discourse, since too many of the measures for quality of healthcare are not discussed at all. Instead, flawed measures like life expectancy and infant mortality rate are used, which understate the quality of American healthcare and overstate the quality of Japanese healthcare. Transitioning to a Japanese-style healthcare system would inhibit both the quality and innovation of the American healthcare sector, in turn leading to fewer new medicines, fewer new treatments, and overall worse quality of healthcare. Though the American system has its problems, many of these problems are being addressed by current law, and we should not risk trying to fix what's not broken. Thank you.
I apologize for the loud noise based on the chair. My opponent has a few flaws in his argumentation that I'll have to point out. For his arguments based on innovation, they ignore that innovation comes from predominantly research universities and other third parties, not the actual healthcare system itself. His stats on survival rates are cherry-picked. They ignore all the people that aren't able to get coverage in the first place and aren't able to go to the hospital because they don't believe they can afford it, and they choose to ignore their issues. There's also the huge advantage that no one in Japan will ever go into bankruptcy, and that the actual healthcare system itself is cheaper and provides a better form of coverage and more coverage to everyone around. Now, there have been a number of steps taken in Japan to solve innovation. Ira Wolf, a Japan representative of Pharmaceutical Research and Manufacturers of America, describes the Japanese market as the best market in the world right now for innovation. A major source for this innovation is that government leverage in the pharmaceutical and medical markets is because the government controls over pricing and access to care. Even the large pharmaceutical companies agree. Robert J. Hugen, a chairman of Pharmaceutical Research and Manufacturers of America, argues that I leave Japan with an even stronger sense that your healthcare system is one of the best in the world, having produced the highest life expectancy and one of the lowest mortality rates. The universal healthcare system and the national health insurance system with low overall spending compared to other countries and should be developed and easy to access to physicians is an overall easy access to physicians is a significant improvement in much of the healthcare environment in Japan in recent years. The regulatory reform that allows for global development to include Japan at the earliest stages, improvement in the clinical trial environment, pricing and reimbursement reform to stimulate the development of innovative medicines, policies to ensure that unapproved therapies and indications are brought to Japan more quickly, and updating the vaccine law to ensure that both children and adults benefit from the newest and most effective vaccines we are developing. The result has been the creation of a much more favorable environment for the development of medical innovation in Japan than in the past, and, I should add, than in almost any other developed country at the present time. When debating over whether or not a policy promotes care innovation, we also have to discuss what is the end goal of the innovation. Under the current system, innovations are made only possible through the profits they generate. This procedure produces incentives only to produce innovations for the sake of profit rather than the sake of need. These innovations are usually expensive to the consumer and only covered by the most expensive and extensive healthcare plans. Standardizing access to insurance is the only way to ensure that everyone can benefit from these innovations. Furthermore, my opponent outlines many reasons why the U.S. healthcare system produces many innovations and Nobel Prize winners. But these are not products of our insurance incentives. Rather, they are a product of university research, institutions, and government support. There are many reforms that can be made to encourage innovation that would not be affected by the adaptation of Japanese system. Patent reform, regulatory reform, and more government support for medical innovation can all resolve the minor implications insurance reform has on medical innovation. Finally, innovation is a trope used by industries that stand to lose some profits if there is a change. If they are truly innovative, they will be able to adapt and make money under the new system. Lastly, low cost increases innovation. As can be seen within the United States itself, T.R. Reid states that the savings can be huge in the high-tech realm that drives U.S. bills so high. An MRI scan on the neck region, routinely around $1,400 or so in America, is $130 in Japan. Cost cutting, like within this argument, is the idea of competition, and that has stimulated innovation and efficiency. He talks about competition within his argument, and it's a common theme in all businesses within the United States. Competition drives innovation. Well, also from T.R. Reid, it shows that Japan has universal coverage, but it's not socialized medicine. It is largely a private sector system. There is government insurance for the unemployed and the elderly, but most people rely on private plans. Japanese doctors are the most capitalist and competitive in the world, but we're talking Japanese-style free enterprise here. There's significant government regulation on the private players. Health insurers are required by law to cover everybody and to pay every plan. The corollary is that everybody is required to have health insurance. The price for a given treatment is identical everywhere in Japan. Officials say this is designed to attract doctors to rural communities. Not accounted for in this data are those not capable of going to the hospital. If you had to compare the evidence against the entire population, the statistics would be drastically different. My opponent continually brings up the idea that we are better on cancer and heart attacks, but this simply ignores the facts that people are not able to access these as effectively in the United States as in other countries. And even in the cases where we do have more people survive, it's because they have insurance plans and have had the money to pay for everything that they expect to go through, rather than having to hope that they'll be able to manage. This is an effect known as the selection effect. Only those who can go into the hospital are those who are insured, and such meaning that this ignores all those who don't have access. That's a huge benefit in the Japanese system because there's coverage everywhere, and you can go to the doctor whenever and for whatever problem you believe you have. In the same article as stated above, Japanese health insurance systems covers everybody, including illegal aliens. It pays for physical, mental, dental, and long-term care. The Japanese are the world's most prodigious consumers of medical care. On average, they see the doctor about 15 times per year. 3 times the US norm of 5 times per year. Also, the number of people who go into bankruptcy in Japan is 0. Ikegami, the program chair of the Department of Health Policy and Management at the Keio Institute School of Medicine, stated in an interview, or was asked in an interview, how many people in Japan go bankrupt because of medical bills. His response, none, or at least there should be none, because first of all, they should be covered. And if they are not covered, then they can get covered by paying back 1 year's premiums. And if they can't pay back 1 year's premium, then they will be on public assistance. This means a system that is completely incapable of driving an individual into bankruptcy. Also, overall, it's cheaper. This is also from T.R. Reid. And yet Japan produces all that high-quality care at bargain basement prices. The aging nation spends about $3,500 per person on healthcare each year. America burns through $7,400 per person and still leaves millions without coverage. Lastly, their overall quality is simply better. Once again, from T.R. Reid. The Japanese have the world's longest life expectancy and the best recovery rates from just about every major disease. Infant mortality is less than half the US rate. Japan usually leads the world in rankings of avoidable mortality. Its effectiveness in curing diseases that can be cured. And even if you agree with the statements presented by his research that it could be as infant mortality could be inflated as much as 40% in the United States, that still does not account for the fact that they are over an entire child more after that 40% is taken away. That still means 1 child per 1,000 more than in Japan are going to die. In conclusion, we should adopt a policy model after the Japanese model. It is both more effective, more efficient, and so much cheaper than the American model as to be in no form of competition. Whenever the United States model only offers competition and innovation, which can both be solved more effectively through alternative means of funding, as well as competition based, as the Japanese model, between the competitors and the doctors themselves, the system would be able to run more effectively and cheaper. Thanks.
When choosing between the healthcare systems of the United States and Japan, there are basically 3 metrics we should use in making that decision. First, which country provides better quality of care? Second, who provides a more equitable access to that care? Finally, which country provides more innovation that will drive future developments that will prevent the diseases that we grapple with in the present? In terms of these metrics, I believe the United States wins decisively. First, in terms of quality. The statistics are simply irrefutable. Yes, the United States has a lower life expectancy than Japan, but my opponent leaves unaddressed the question of what causes this lower life expectancy outside of issues of healthcare. As I said before, the United States has nearly 10 times as many homicides as Japan does, and has twice the accident rate in terms of transport. The Americans simply are exposed to more dangers in their everyday lives than the Japanese are. Moreover, they live a less healthy lifestyle. Yet, once these people have diseases, the American system is certainly better. In heart disease and in cancer, these are the 2 primary causes of death in the United States. The United States has a much lower mortality rate for these 2 diseases than Japan does. I think that says everything you need to know about the issue of quality. As for access, this is certainly a good point. The United States leaves tens of millions uninsured, and that is a problem that the Affordable Care Act has attempted to address. The Affordable Care Act has provided the individual mandate, provided subsidies to consumers, and provided new regulations that will ensure that health companies cannot discriminate against individuals on the basis of, for example, pre-existing conditions. All of these measures taken together will end up vastly reducing the number of uninsured in the United States. Again, the question is, who is not covered by the United States system once these policies are implemented? The answer to that question is undocumented immigrants. That is separate from the question of the healthcare system. Most of the people who will no longer have health insurance after the Affordable Care Act are illegal immigrants. And we can have that discussion, but it's not one that is important for this discussion of which has a better healthcare system. The final issue is innovation. Innovation is certainly the major advantage of the American healthcare system. My opponent argues that things like nonprofit universities and research universities are the ones that are driving reforms. Yet he leaves unaddressed the issue of where new pharmaceutical drugs are coming from. They're not coming from universities. In large part, they are coming from companies searching for profit. This may seem strange to us, or it may seem distasteful to be searching for medicines in the guise of profit, but it works. The United States has been responsible for 80% of new pharmaceutical drugs. These are life-saving drugs. These stop major conditions and help people have a better quality of life. Yet, under Japan's system, where a central committee organized by the government is able to determine which procedures, which treatments, which medicines get reimbursed under healthcare insurance, or health insurance. In the United States, it's a decentralized system, where essentially, if you don't like the coverage that your insurance offers you, you can choose a different insurance plan. This is the basis for my argument about competition. When you have that choice, you can choose to try new experimental drugs, new experimental treatments that will offer a possibility of hope that all current treatments don't have. So when we have this competition, we have the access to new and affordable drugs. My opponent makes several arguments against the American healthcare system. Certainly bankruptcy in terms of medicine is a major issue in the United States. But the United States has addressed this issue through the Affordable Care Act by providing subsidies to individuals to help them purchase healthcare insurance. Moreover, it also prevents people from, the reason people tend to go bankrupt in the status quo is because they don't have health insurance in the first place. So when they get some sort of major disease like cancer, they're not able to afford coverage out of pocket for their health care. Yet if we increase the number of people who have that access to healthcare insurance, we will be able to resolve that problem. So he also argues that innovations are happening right now in Japan. Certainly this is true. They are trying to make their healthcare system more dynamic, more competitive, more innovative. But there's no arguing with the status quo. With statistics, the United States simply has more innovative treatments available to people in the United States. He further argues that Japan provides a model of universal coverage that isn't based in socialized healthcare. So yes, the people in Japan are able to purchase the health insurance out of their own pocket. The problem is that the terms of that insurance plan are determined by the government, as I stated before. He also argues there's a selection bias in terms of people surviving cancer and heart attacks in these mortality statistics. But this simply strains credulity. People don't check their bank accounts before they decide to go in when they have a heart attack. It's not something people do. Because of emergency care, people can walk into the emergency room, even if they can't afford it, and still receive coverage. So, in terms of selection bias, there isn't any. People in the United States simply have a better chance of surviving major diseases that kill us all. In short, the United States system works well, and our major problems are already being addressed by the Affordable Care Act. And I believe that transitioning to a Japanese-style healthcare system will present major problems that will deteriorate quality, innovation, and equity.
So as you can see, there's a lot of issues at stake in what type of system and the type of insurance programs that are adopted in America. And because we covered a lot here in the past 30, 40 minutes, we thought it'd be best if we left some time here at the end for questions from you all that you might have in terms of some of the issues that were discussed here. So, questions? And I also can't see anybody, so I'll have to go. Yes, ma'am.
When you talk about Japan, you talk about all the islands in Okinawa and seven islands also.
I mean, the healthcare system is set by the central government in Tokyo. There are certain portions of the islands that are like American military bases, and Japanese government regulations don't really apply there. In terms of thousands of islands in Japan, they all pretty much have the same system based on these regulations.
And the statistics are an aggregate from each island. The statistics include all of Japan, not just the main islands.
One of the criticisms that emerges in the literature about this too is because Japan has a more centralized government and doesn't have the same federalism issues of states versus the federal government that we have, a lot of these reforms are easier for them to do at a national level. Or if you did that here, you'd have a lot of barriers at the state levels that might inflict some of them. So there is a comparativist question to be asked there. It's much beyond the scope of what we were doing here tonight. Yes, sir.
No, okay. I think this debate is not fair. It's like every country has their own unique problem. The United States has its own unique problem. Japan has its own unique problem because of like different history, different cultural backgrounds. So it's simply by adopting a system from another country, it's not too realistic for whoever is speaking that system.
Oh, it was a concern that we had when we formatted these debates, right? That's one of the things we always worry about is balance, right? Make sure both sides have legal things to say. And that's why we limited it to the question of not wholesale adopt everything Japan does, but just the universal multi-payer healthcare system, as opposed to the status, what we have in America and the multi-tiered private, public partnerships that we have for health insurance. So we tried our best, and there's obviously always going to be some differences that make the comparisons a bit harder, but that's how we try to resolve it. So if you think of it less as, well, what happens if we put all of Japan's system in ours, and more of just, well, what if we adopted this multi-payer system? It kind of refines a lot of those differences away. Because that's what a lot of the healthcare reform debates are, right? There's 100 different models, one for each country. But for the most part, they all follow the same thing. They're either the single-payer systems that we see in Canada and parts of Europe, or multi-payer systems that we see in Japan, France, and a few other countries. And so there are enough commonalities that there is kind of a larger question of just that general reform to balance out.
I think it's easy to overstate differences among healthcare systems. This debate kind of drove that point home. But in a lot of ways, the United States and the Japanese systems are very similar, especially after the implementation of the Affordable Care Act. Since before that, kind of major difference between these two countries was that whereas Japan required every person to buy health insurance, the United States just kind of had a laissez-faire attitude that you could be responsible for your own decisions. But now that that regulation is going to be implemented, so there's not that much difference. The primary difference between the Japanese and American healthcare systems are in terms of how benefits are decided. They're largely decided by the government in Japan, whereas benefits are kind of decided on a state-by-state or employer-by-employer basis in the United States.
The other thing that's missing is the Japanese system actually parts of it were introduced as part of the debate over the Affordable Care Act, but eventually fell out of the bill, and it was called the public option, in which there would be a government-supported insurance option for people, which is very similar to what the Japanese system has, but that couldn't survive the political process. Yeah, I think. Okay.
I have a question for this gentleman. Yes, sir. What political system does Japan have in terms of government?
As far as their political system,
Constitutional monarchy.
yeah, it's a constitutional monarchy controlled predominantly by their, I don't know what
The Japanese diet.
their parliament.
Yeah, it's a parliamentary system.
Yeah. I just don't know.
The VA system falls under, because it's not not a majority of people that have access to it, it falls under its own system, but it's mostly akin to Medicaid and Medicare. More than anything else. I'm sure there's a lot of differences, but
It's even more of a single-payer system than Medicaid because they have hospitals that are run by the government.
Right, veterans in hospitals all over the world.
yeah. Yes, sir.
Speak of the
structure of the American system where you get reimbursed by an insurance company. It tends to prioritize specialists. So, your doctor in the United States is almost always a specialist. There's some branch of medicine that they focus on. There's very few general practitioners in the United States compared to Japan. In Japan, they have a shortage of specialists and a surplus of these general practitioners.
Before they came in here, I'm not sure if they're out shortage until 2035. The government was subsidizing people to go to school to be doctors because the doctors right now are overworked and underpaid. Do you foresee that for the ACA?
Under the current Japanese model, there is a shortage of doctors, and there's a couple of compounding problems with that. One is that they don't have as many people currently of the age to be a doctor because a large portion of their society is getting into retirement age. And in fact, by 2025, I believe, they're expecting to have 40% of their population be over the age of 65. And as we discussed earlier, there is this discrepancy where they have a vast majority of general practitioners, and yes, they are overworked currently and underpaid, just as far as our standard would be for doctors, but they're still making more than 6 figures a year, and would be, if they were in the United States, either very high middle class or low middle class, instead of comfortably middle or the upper class.
There's this other issue that's kind of larger than the healthcare debate of income inequity in the United States. There's very comparatively low taxes on high income earners in the United States. So there's no real shortage of people who want to become doctors or want to become lawyers or any other occupation that pays a lot of money. Japan have relatively more progressive laws.
The ACA is not going to affect us the way that the Japanese system would, because it's not lower in earning by that significant margin.
You see, it takes up 17% of our economy right here. What is it?
Japan's current economy is only, I
You
have the
said they
statistics
spent
here, it's
something like $4,000 per person.
Yeah, $3,400.
So that would work out. a little
9%
less.
of the GDP.
It's 9% of the global economy compared to 17. And so you don't foresee any doctor shortage.
The difference between the two is that in Japan, they save a lot of money through saving money on procedures themselves and through medicines, where we spend $160 on a bottle of pills, they'd spend $7. Because the government doesn't ask companies what they want to cost, they tell them this is how much you will want to sell your product for. And even though that's not the free market we think of, it still encourages competition because those companies want to get the best out of their money. The hospitals, the doctors want to have the best MRI machine at the lowest cost. So it actually forces innovation through a different method.
And there's other doctor shortage issue in America that's going on before the ACA. It's been mostly geographical driven more than it is just a sheer number. And that's hard to make money in a rural area as a doctor. It's hard to support that type of practice in small areas. And so the places that's most acute are in the outlying areas throughout the United States, and that's also where we see a lot of health problems emerging. It's really hard to create the incentive structure correctly under any of these systems to resolve that problem. So, yeah, there's still going to be shortages, but there are probably going to be more rural versus urban divide than there is any, than it is going to be mostly some of the other divides that are presented. Does that answer? Okay. Any other questions? Well, if not, well, thank you all. Oh. Sorry, I can't see.
What about exemptions are is everyone required for the same insurance, or are they exempt from
In Japan, it is required of every individual to pay some amount of insurance if they are, for any reason, incapable of having a job or retired or anything like that. And the government covers those payments instead, and it's a public. They have a public payment for those individuals, but they're still covered by some.
So the government officials also have to use the same system, whereas the ACA is a government.
Well, that's pre-existing, the ACA. There's all sorts of different tiers of healthcare in the United States because we have so many different programs. Every state has different requirements for insurance. So there are exemptions in that respect. There's also exemptions in terms of your age, which is only Medicare recipients have to be 65 or 62 or 68. So there's just because of the nature of the system of the United States, there are these exemptions because there's no single provider of healthcare in the United States. It's thousands of decentralized hospitals, private companies or philanthropic organizations, and whatever else. It's not really an issue of exempting, like, there's not a government exemption for the American before it's just, there are certain requirements that are
You're quite welcome. We'd like to thank everybody for coming out tonight. I mean, this is what we thrive on, what we like to do. And for those of you who are interested in joining the debate team, please come by and see me or Kurt Pafelski, who's the assistant director of debate here. Both of us will be willing to talk with you about how you become a member to participate in events like this or competition events that we travel to all the time. So thank you all very much for coming out. Those of you who are in my classes and at King College of Credit, there's a person sitting up in the corner who's waving his hand to you right now. If you can give them your name, they'll write it down for you so I'll know you were here. So I can see. Yeah, don't forget to get your passport stamps. Thanks, everybody.
You can do it. Come on. No, one more now.
What am I doing? We're like so busy.
Get all your hands.
Yeah, two.
He's willing to.
I'm probably, I don't think I'll go to the markets.
See, that's how I'm feeling. I'll get one, but it's going to sit there.
I nearly cried in joy today because my professor said, "Hey, Phil," because he was going to have a panel at the conference this year. And he wanted me to be on it. And he was like, "Hey, Phil, not enough people signed up." I was crying.
Yes.
Good, bad, I'm the guy. Was I here though? Can you really say? I don't. Just a big guy. To be fair, I don't really speak just I know. Oh no. So they
That's why I came to class.